Now students, starting with the next chapter in CNS, that is called as anti-epileptics. So in this chapter now we are going to discuss the drugs which are used in epilepsy. Okay, now epilepsy, as we know that it is basically जो हम आमतौर की बोलचाल की भाषा में बोलते हैं मिर्गी, and basically it is a condition in which there are recurrent episodes of seizures. So these seizures are classified into, they can be generalized, they can be focal, and they can be unclassified. Some seizures are unclassified. Now in generalized seizures, what we have grand mal epilepsy, that is generalized tonic-clonic seizures, and then we have absent seizures, that is petit mal epilepsy. Then we have myoclonic, then only tonic or only clonic, and even atonic. So these come under generalized seizures. Then in focal seizures we have simple partial. Now simple partial can be also called as Jacksonian epilepsy, and complex partial. And complex partial is called as temporal lobe epilepsy or psychomotor, right? Then in unclassified we have different types of epilepsies like febrile seizures, then infantile spasms, and then a very interesting Lennox-Gastaut syndrome, that is a specific type of epilepsy with impaired cognitive function and a very specific ECG wave. So these are this is the classification. Now let us see the classification of epilepsy. Now let us see the drugs which are used in epilepsy. तो पहली जो family होती है, the first family is the GABA family. So let's see what are the drugs acting on the GABA. So I'll just make a diagram and I'll explain it through this diagram. So this is the presynaptic receptor of GABA, and this is the postsynaptic receptor on which we have GABA A and GABA B, right? So this is GABA A and this is GABA B. Now here from glutamide we make GABA. So from glutamide GABA is made. Now this GABA is here, it is released. Now after release, then this is metabolized by GABA transaminase. This is the enzyme that metabolizes GABA, and there is a receptor transporter here. This is known as GAT1. This is the reuptake, okay? And then GABA also attaches to the receptors A and B. So what are the drugs that are acting here? So the first drug that we will see, one second. So GABAergic, GABA mimetic बोल सकते हैं, GABA की एक्शन को बढ़ाने वाला वो होता है valproate, right? Then there's a drug which inhibits the reuptake. So valproate has a positive action. Here an inhibitory action. So inhibition of reuptake of GABA in the neurons is done by tiagabine. Okay. Then this GABA transaminase inhibition. So we are inhibiting the metabolism of GABA. We don't want GABA to be metabolized so fast. So the drug which is inhibiting the metabolism of GABA is vigabatrin. Okay. Then the drug which will increase the release of GABA. So a positive response here. That is gabapentin and pregabalin, right? Then drugs which are acting on GABA A receptor, they are barbiturates and benzodiazepines. ठीक है? So GABA के ऊपर जो एक्टिविटी है, बेसिकली एक और ड्रग है टोपिरामेट, वो भी GABA की एक्टिविटी बढ़ाती है. तो जैसे वैल्प्रोएट कर रहा है वैसे ही टोपिरामेट is also increasing the activity of GABA. Then there are drugs which basically act on ion channels. So there are multiple types of ion channels which play a major role in epilepsy, right? तो कौन-कौन सी channels हैं वो समझते हैं उसको. तो again we'll try to understand it with a diagram. So here this is the presynaptic receptor and this is the postsynaptic membrane. So now here whenever there is an entry in the sodium and there is an increased action potential, then it causes release of substances. Now there are various substances and let's see what are they. The first I'll say the drugs which inhibit the sodium channels when these are open. So the entry of sodium, inhibitors of sodium channel. So in this, what do? They inhibit the drugs, they inhibit the channel in open state, and so they prolong the inactivated state of the sodium channel. So they become refractory. So the drugs which are inhibiting the sodium channels, what are they? So sodium channels, the drugs which inhibit the sodium channels are phenytoin, then carbamazepine, valproate, ये तो है ही है ना. उसके बाद आती है टोपिरामेट, then lamotrigine, then zonisamide, then rufinamide, then cenobamate and lacosamide. So these are the drugs that are acting through the sodium channels. So many drugs, they are acting and inhibiting the sodium channels and thus reducing the depolarization as you can see here. ठीक है, सो ये पूरी एक्शन इनकी हो गई. उसके बाद फिर देयर आर सम पोटेशियम चैनल्स, एंड इन पोटेशियम चैनल्स का नाम है KCNQ. potassium channel, right? So iske upar then there are drugs which inhibit this potassium channels. Then there are some calcium channels. They are T-type calcium channels. Then there are some drugs which inhibit this calcium channel. So what are those drugs? Let's see. The drug which inhibits the calcium channel is ethosuximide. The drug which inhibits the potassium channel is retigabine. Okay. Then there are AMPA receptor. AMPA and glutamate and aspartate, they are the excitatory amino acids. So now the drug which inhibit the AMPA receptor, that is a new drug, that is perampanel. Okay. There is a receptor which is called as kainate receptor, and this kainate receptor is inhibited by topiramate. Okay. Another receptor is there, that is AMPA receptor. AMPA receptor is inhibited by felbamate. Okay. उसके अलावा कुछ एडिशनल ड्रग्स होती हैं जिनकी मिसलेनियस सी एक्शन होती है, वो मैं आपको यहाँ पे लिख के बता देती हूँ कि जैसे एक ड्रग होती है लेवेटाइरासिटाम. सो दिस बेसिकली दिस बाइंड्स टू दी SV2A receptor and it inhibits the depolarization and vesicular release. There's another drug brivaracetam. These both drugs, they bind to the SV2A receptor and they inhibit the vesicular release. Okay. Then there is a drug which is called as lacosamide. We have written the name here also. Lacosamide, and even there's a drug which is called as yes. So this inhibits the CRMP2 receptor. So it inhibits the CRMP2. Then another drug has come up which is called as cannabidiol. And this cannabidiol, it basically is a cannabidiol agonist. It attaches to the CB1 receptor and it is CB1 receptor agonist. Okay, so these are the various drugs, the various actions, the GABA family, then the ion channel family, in which we have sodium channel inhibitors, potassium channel, calcium channel inhibitors, then the excitatory neurotransmitters, AMPA, kainate, and sorry, this is NMDA. I forgot, I wrote AMPA here. This is NMDA. So the excitatory neurotransmitters inhibitors are these. Then some drugs which are acting by some miscellaneous routes. Okay, so these are the drugs, these are the important drugs which we have to study for the anti-epileptic. Anti-epileptic. A lot of questions are asked on epilepsy, and so it is something that you have to be very, very good at. The first, now let's take the families one by one. So barbiturates and benzodiazepines. We have earlier discussed barbiturates and benzodiazepines in detail in sedative hypnotics. So we know all their contraindications and indications. Barbiturates may, the drug which is basically phenobarbital. It is used for GTCS in infants, right, and causes hyperkinesia in older children, so not used there. So GTCS in infant के लिए use कर सकते हैं. Barbiturates cause paradoxical excitation, and also they are contraindicated in porphyria. They also have a lot of interactions, so they are not very much preferred. Now benzodiazepines की अगर हम बात करें तो benzodiazepines में the drugs that we have are diazepam. They are very commonly and very preferably used in epilepsy. Diazepam, lorazepam, and clonazepam, and clobazam. Now these drugs, they are GABA facilitatory and they increase the frequency of potassium chloride and channel opening. They are used IV for status epilepticus. Okay. Here the drug which is used is lorazepam. Then given by per rectal route, they are used in febrile seizures in children. Okay, and they are also having good sedative effect. So these drugs cannot be indicated for long-term use because they have they develop tolerance. So that is the reason. The second the drug that is very important is phenytoin. Now phenytoin, as we all know, that it is also a drug which is antiarrhythmic. It is also an antiarrhythmic, and it is in class 1B, where it is used for the treatment of digitalis induced arrhythmias. Now इसका एक congener होता है phosphenitoin, and this phosphenitoin can be given IV or IM for status epilepticus. Right? Now this drug acts by inhibiting the sodium channels. It is very commonly used in GTCS and partial seizures. In both GTCS and partial seizures it can be used. Then phenytoin के कुछ important features होते हैं. Phenytoin causes saturation kinetics. So that means it has as the concentration increases, the metabolism changes from first order kinetics to zero order kinetics, and then in zero order kinetics there is accumulation and toxicity of the drug that can occur. Then toxicity, when there are toxic, then oral dose can result in cerebellar symptoms. We get cerebellar symptoms, that is ataxia, vertigo, nystagmus, and diplopia. So these are the symptoms which usually the patient presents with. Then phosphenitoin के बारे में important है, it has to be given slowly, स्लो IV इन्फ्यूजन देना है. अगर आप इसको फास्ट दोगे then it can result in arrhythmias and cardiovascular collapse. Okay. Then when this drug is used for a prolonged duration, prolonged use of phenytoin can result in a lot of side effects. It results in first thing gingival hyperplasia, that is gum atrophy. This is because of increased platelet derived growth factor in the body. Then it also causes hirsutism, megaloblastic anemia, vitamin D deficiency. So it results in rickets and osteomalacia, right? It also causes vitamin K deficiency, hyperglycemia, hypersensitivity, and if given in pregnancy, then it can result in fetal hydantoin syndrome. And what is fetal hydantoin syndrome? It is basically cleft lip, cleft palate, and microcephaly. Okay, so this is there. Osteomalacia cannot be ameliorated by giving vitamin D because some more proteins are involved. So osteomalacia ho gaya and you give vitamin D, it is not enough. Then it also can result in lymphadenopathy. Lymphadenopathy हो सकती है. Then it can result in malignant lymphoma. It can inhibit the ADH release. And lastly, it is also a very good enzyme inducer. So it increases the metabolism of various drugs. So this is about phenytoin. Very important points, and a lot of questions are asked on this phenytoin. The next drug that we have is carbamazepine and oxcarbazepine. Now carbamazepine, this also blocks the sodium channels. This also has action on the sodium channels, and this is the drug of choice for partial seizures. They can also be used in GTCS. Then carbamazepine is also the drug of choice for trigeminal neuralgia and also for post-herpetic neuralgia. Then carbamazepine is also used in bipolar disorders. Plus, it is also used as an anti-diuretic in diabetes insipidus. It is also an enzyme inducer and induces its own metabolism also. So more doses required. एडवर्स इफेक्ट्स में इसके यूजुअली डिजीनेस, हेडेक, एटेक्सिया, डिप्लोपिया, निस्टेगनेस, ये सब होते हैं. कुछ एडवर्स इफेक्ट्स होते हैं जैसे इट कैन रिजल्ट इन रैश, aplastic anemia, SJS, and liver toxicity. These are some features which are seen with carbamazepine. Carbamazepine is also contraindicated in pregnancy because it can also result in cleft lip and cleft palate in pregnant and children born to pregnant mothers who are taking carbamazepine. Then there is a new drug also in this. That is, I'll write it here, carbazepine. It is a new drug which is used in focal seizures. It is also a sodium channel blocker. So this is a drug which is based on carbamazepine only. The next important drug that we have is valproate. Now valproate is a very, very good drug. Why good? Because it has got all the actions. It acts on all spectrum of actions. It is a sodium channel blocker. Then it increases the activity of GABA. Right? It inhibits the calcium channels. It reduces the release of glutamate. So ये जो चार एक्शंस है ना, सोडियम को, कैल्शियम को ब्लॉक करना, गाबा को बढ़ाना एंड ग्लूटामेट को कम करना, ये सारी एक्शंस वैल्प्रोएट करता है. एंड इट इज़ द ड्रग ऑफ चॉइस इन GTCS, इन एटोनिक, इन एब्सेंट सीजर्स. एटोनिक हो गए, क्लोनिक हो गए, टॉनिक हो गए, सारे सीजर्स, एंड मायोक्लोनिक, ऑल्सो यूज्ड इन लेनॉक्स-गैस्ट्रोड सिंड्रोम. Then it is used in infantile spasm, and it is also used in partial seizures. So valproate is a drug which is having all the actions, and so it is used in all types of epilepsies. Then other uses, valproate के बहुत सारे दूसरे uses हैं. It is the drug of choice in bipolar disorder, right? Prophylaxis of migraine. Then also used in tardive dyskinesia. Bipolar में it is also used the drug of choice in rapid cyclers, जिनमें more than 4 cycles in a year होती हैं, तो वहाँ पे valproate is very much used. Okay, now let us go to the adverse effects and other interactions. Now it is a drug. It is, first thing is valproate is an enzyme inhibitor. Adverse effects में आप देखें अगर तो ये weight gain करता है, alopecia, tremors, carnitine deficiency, and irreversible liver necrosis, which is more in children less than 2 years. Okay, so valproate is contraindicated in children less than 2 years, and अगर less than 2 years में epilepsy होती है तो फिर then we don't give valproate. If this epilepsy is more in children more than 2 years, then we can use. Then अगर less than 2 years में हो रही है तो the drug that we use is ethosuximide. Okay. Then it also causes acute pancreatitis and hyperammonemia can be also used. If it is given in pregnancy, then it can result in neural tube defect. So valproate should be, if the patient is epileptic, then give folic acid to the patient. Valproate can also cause PCOS in girls. Okay, so valproate is a very good drug and it has got multiple uses, and but adverse effects होते ही हैं, उनको देखते हुए फिर हमें लेना है. The next drug that we have to study is ethosuximide. Now ethosuximide is the drug of choice in absent seizures. This basically acts by inhibiting the calcium channels, T-type calcium channels. So it is the drug of choice only in absent seizures, and it is specifically in children less than 2 years of age. It is used, right? There is a drug which is its congener only, that is trimethadione, like ethosuximide, but this causes an adverse effect which is called as hemerotopia, which is photophobia and glare effect. So trimethadione causes hemerotopia and photophobia and glare, which is. Then let us see other drugs. Other drugs may the drugs which are acting through the GABA channel. So in this we have vigabatrin, which is an irreversible inhibitor of GABA transaminase. Okay, so it increases the GABAergic activity. It is the drug of choice for infantile spasms associated with tuberous sclerosis, right? In all other infantile spasms, the drug of choice is ACTH. It is only in infantile spasm associated with tuberous sclerosis that we use vigabatrin. The adverse effect of vigabatrin is that it causes visual field defects due to retinal atrophy. So this is a side effect which has to be taken care of. Next drug that we have is lamotrigine. Now lamotrigine is a very broad spectrum anti-epileptic drug, and it is used for various seizures, including absence seizures and myoclonic. It is indicated for depressive phase of manic depressive psychosis. It causes adverse effects, that is Stevens-Johnson syndrome and toxic epidermal necrolysis. These are important adverse effects of this drug. Then the next drug that we have is gabapentin. Gabapentin increases the release. It also inhibits, इसके दो mechanisms है. It first of all increases the release of GABA, and it attaches to the alpha 2 delta 1 subunit of presynaptic calcium channels. Okay, so this is useful in GTCS and in partial seizures. Then also used in diabetic neuralgia and post herpetic neuralgia. Another drug which is similar to gabapentin is pregabalin. Okay, so this is about gabapentin, vigabatrin and lamotrigine, the drugs which are acting through the GABA mechanism. Then there are some more drugs of epilepsy. Then there is this drug which is ganaxolone. Now this ganaxolone is basically a neurosteroid. Okay, this is synthesized in the brain, and it is found to be effective in absent seizures, in infantile spasm, and it is also found to be effective in catamenial epilepsy. Catamenial epilepsy is epilepsy which occurs during menstruation. Okay, so that is ganaxolone. Then another important drug is topiramate. Topiramate also has got almost all the actions. Sodium पर act करता है, calcium पर करता है, GABA पे करता है, glutamate पे करता है. So this is also a drug which can be used in almost all type of epilepsies. So this is used in GTCS. This can be used in partial seizures, and topiramate is also used in Lennox-Gastaut syndrome. Okay, this drug, it causes weight loss. Then there is another drug, zonisamide and topiramate. They both cause renal stones also, because they inhibit the carbonic anhydrase, so they cause development of renal stones. Then next drug is felbamate. Felbamate is basically an NMDA blocker, NMDA receptor blocker. So this is used in drug-resistant epilepsies, but it causes hepatotoxicity, and also causes aplastic anemia. So not very commonly, which is इसलिए इस drug का इतना ज़्यादा use नहीं है. Then next drug that we have is perampanel. Now perampanel is a drug which is basically a new, and it is AMPA receptor blocker, and this is used for focal seizures, right? Then levetiracetam and brivaracetam. These are two drugs which are basically, they modify the release of GABA and glutamate by attaching to the synaptic vesicular 2A protein, right? The adverse effects में आता है because CNS adverse effects like irritability, aggression, and lability of mood. Okay. Then a very important drug, magnesium sulfate. This is the drug of choice for treating convulsions during labor, which is also called as eclampsia. Okay. Then other drugs that we have is tiagabine. This is used in partial seizures, and it is basically inhibitor of GABA reuptake. That is, GABA transporter होता है GAT1, उसको ये inhibit करते हैं. Then we have lacosamide. It's a new drug for partial seizures, and this basically blocks the CRMP2, that is collapsin response mediator protein, and so it blocking of this results in inhibition of neurotrophic factors like BDNF and NT3 on the axonal and dendritic growth. So this is the action of lacosamide. Then there is a new drug, stiripentol. What is stiripentol? It is a new oral drug. It increases the GABA activity, and it is approved for Dravet syndrome. Okay, what is that? Dravet syndrome के लिए we use stiripentol. Then another new drug, rufinamide, is a recently new drug which is used for Lennox-Gastaut syndrome. Okay, so this is also important. Rufinamide used for Lennox-Gastaut syndrome. Then this drug which is remaining, that is reticabine, which is a potassium channel blocker. Wait, it is a potassium channel opener, not a blocker. Okay, and this reticabine, it is approved for use in partial seizures. Adverse effects reticabine के होते हैं blue pigmentation of iris. It also causes urinary retention. So these are the side effects seen with reticabine, which is a drug acting on potassium channels. Then there is a new drug which is cenobamate. जैसे felbamate होता है ना, तो cenobamate is also used for focal seizures. Felbamate तो NMD के ऊपर act करता है. This acts only on sodium channels. Then another new drug, that is cannabidiol. Now this cannabidiol is a CB1 receptor agonist. Now this cannabidiol is also used for Lennox-Gastaut syndrome. It is also used for Dravet syndrome. Right? It is the first drug approved which is having marijuana derivatives. First FDA approved drug containing this. Now another important situation is epilepsy in pregnancy. So now pregnancy, see, all these epileptic drugs are having very huge teratogenic effects. So most important step is to control the seizures. First thing, female is already on epileptic drug, continue the same drug, add folic acid. Add folic acid and continue same drug, because when you change the drug, many times the epilepsy is precipitated. So folic acid is to be added to prevent neural tube defect. अगर phenytoin ले रहे हैं, then add vitamin K also during labor if phenytoin is being taken. Okay. Now, if a female is planning to become pregnant, then she should be stabilized on minimum number of anti-epileptic drugs. Now, newer drugs have got less teratogenicity than the older ones. Valproate is the most older one. However, we'll select the drug based on the epilepsy also. Now, safe अगर हम बात करें तो carbamazepine. Carbamazepine is a safe drug, and another drug is lamotrigine. It has got a very wide spectrum also, and it is also very safe. Then topiramate can be used except for absent seizures. Folic acid हमें prescribe करना ही है, 400 microgram folic acid लेडी को लेना ही है, ठीक है. So this is the important thing during epilepsy in pregnancy. एक Lennox-Gastaut syndrome पे questions आते हैं. So what is Lennox-Gastaut syndrome? This is basically a triad of varying epilepsies, it has got frequent seizures. Then there is cognitive dysfunction, and EEG में we get slow spike wave complex. This is very specific in EEG. The first line drugs that we give are rufinamide, valproate, and benzodiazepines. Right? Second line drugs are felbamate and topiramate. Okay? So this is Lennox-Gastaut syndrome. So with this, we complete the epilepsy part of CNS. So now let us see in CNS drugs the next important component. It is alcohol and methanol. Now this is an important chapter because a few MCQs many times are asked on these drugs also. So let's see about alcohol and methanol. Now alcohol is a basically CNS depressant, and it results in psychological as well as physical dependence, right? So this is the feature of alcohol. Now it follows zero order kinetics. So saturable kinetics होती है, and so it can result in toxicity at higher concentrations. Acute ingestion of large quantity of alcohol can result in hypotension, and chronic ingestion of alcohol can result in hypertension and also dilated cardiomyopathy. Then it is seen that moderate consumption of alcohol has a cardioprotective effect. And what is that moderate consumption? It is 18 to 20 grams daily. Has a cardioprotective effect by increasing the HDL and reducing the LDL. But what effect it will have on liver, ये आप सबको पता ही है. Now metabolism देखते हैं alcohol का. How does it get metabolized? What is the metabolism? Now metabolism ऐसे होता है that alcohol is converted to acetaldehyde, right? And acetaldehyde is converted to acetic acid. This we have studied in organic chemistry also. And the enzyme which causes conversion of alcohol to acetaldehyde is alcohol dehydrogenase. And acetaldehyde to acetic is aldehyde dehydrogenase. Okay? So this is the metabolism of alcohol. Now what happens? There is a drug. What is that drug called as? Disulfiram. Now this disulfiram, it inhibits this alcohol dehydrogenase. So because of the inhibition of I'm so sorry. It inhibits aldehyde dehydrogenase. And because of the inhibition of aldehyde dehydrogenase, there is increased quantity of acetaldehyde. So it causes increased acetaldehyde in our body. And this acetaldehyde results in unpleasant symptoms. And so disulfiram is the drug of choice in patients who want to leave alcohol. Now there are some more drugs which have action like disulfiram. So what are those drugs? Disulfiram like action. They are chlorpropamide, cefoperazone, moxalactam, cefomendol, metronidazole, greaseprevin. So these are some drugs which have a disulfiram-like action, and if they are given to a patient who is alcoholic, then they can result in accumulation of acetaldehyde and lead to severe distressing reactions. Now, chronic alcohol consumption also induces the microsomal enzymes. So it is seen that increased generation of the toxic metabolite of paracetamol is seen more in alcoholics. Okay. Then another thing, alcohol causes hypoglycemia in diabetics who are taking the drugs. So this is important. This alcohol metabolism is important, and disulfiram-like reaction. These things are very important. Now, what is the treatment of alcohol dependence? How do you treat the alcohol dependence? Now we know alcohol causes physical as well as psychological dependence. So first step is to prevent the withdrawal symptoms, and second is to avoid relapse, right? So withdrawal के लिए what do we use? What do we do for withdrawal? For withdrawal, benzodiazepines, that is diazepam and diazepoxide. These are given to prevent withdrawal. Okay. Then so these are number one. Second, naltrexone can be given to reduce craving. Okay. And the third, another drug is there, that is acamprosate. Acamprosate is NMDA antagonist, and it is used, please remember, maintenance therapy for alcohol abstinence. मतलब a patient who has left alcohol, to avoid relapsing, it is acamprosate is used to maintain the therapy. So we have diazepam to prevent the withdrawal, naltrexone to reduce the craving, and acamprosate. And the next that we have is disulfiram, which we have already seen. Now it is contraindicated in physical dependence patients. Okay, and another category of drug, topiramate, which is an anti-epileptic, and ondansetron. They also are used to reduce the cravings. Okay, next we come to मिथाइल अल्कोहल. सो मिथाइल अल्कोहल के बारे में इंपॉर्टेंट है बेसिकली उसकी पॉइजनिंग. तो मिथाइल अल्कोहल क्या है, इसका मेटाबॉलिज्म देखो. मिथाइल अल्कोहल gets metabolized to formaldehyde, which gets further converted to formic acid. This is by alcohol dehydrogenase, and this is by aldehyde dehydrogenase. Okay, just like alcohol, this is also metabolized. Now formaldehyde and formic acid. Now this formic acid is responsible for the toxicity. It causes metabolic acidosis, it causes blindness and death, right? So accumulation of this formic acid results in blindness and death. It causes optic damage, retinal damage. Now this treatment, how do you treat? So treatment of poisoning. So first thing that you do is gastric lavage. So you reduce the absorption, any more absorption from the stomach. Second, you give soda bicarb to correct acidosis. Third, we can use ethanol, because what will ethanol do? Ethanol will competitively inhibit conversion of methanol to formic acid. What will ethanol do? Ethanol will basically take the metabolism, this metabolism, ethanol अपनी तरफ मोड़ लेगा. It will divert the metabolism to ethanol metabolism, and so methanol will not be metabolized, so formic acid will not be generated. And the fourth drug that we have is fomepizole. So this fomepizole, it is a specific inhibitor of alcohol dehydrogenase. So this alcohol dehydrogenase is inhibited by fomepizole, and so the metabolism of methanol is inhibited. So this fomepizole is given. Lastly, you can also use folic acid, or you can use folinic acid, because they will convert formic acid to carbon dioxide. So the toxic metabolite will also be inhibited or removed. Then in methanol and ethanol, one more item is there that we study, that is ethylene glycol. Now what is ethylene glycol? Ethylene glycol is used basically as an industrial solvent, and it is used as antifreeze in industry. Now how is it metabolized? Now ethylene glycol gets converted to glycoaldehyde, which further gets converted to glycolic acid. So toxicity happens, and what is the toxicity? Then it causes renal tubular acidosis. This glycoaldehyde and glycolic acid, they cause renal tubular acidosis, and there is excretion of oxalate crystals in urine, right? So again, the drug of choice here is fomepizole. This is the drug of choice for ethylene glycol poisoning. Okay, so this is about ethylene glycol. Next, let's see the opioids. The next category of drugs that we have to discuss in CNS is opioids. Now opioids, as we know, they are substances obtained from papaver somniferum, which is poppy plant, and morphine is the prototype in this opioids, and the receptors that we have are mu, kappa and delta receptors, right? Mu receptor mediates sedation, then analgesia, constipation, respiratory depression, constriction of pupil, that is meiosis, euphoria, and truncal rigidity. So you can say that majority of the actions of morphine are mediated by mu receptor. Then kappa receptor mediates dysphoria, not euphoria, dysphoria, that is there are psychomimetic effects are there. Then it also mediates constipation and analgesia, right? And delta receptor बहुत कम चीज़ें करता है. It basically mediates spinal analgesia, hormones and neurotransmitters release. So these are the major factors, major actions which are mediated through the receptors. Now there are some endogenous opioids. Endogenous opioids में हमारी बॉडी में होता है endorphins, and these endorphins are managed by mu receptor. Then we have dynorphins, and they are mediated by kappa receptor. And then we have enkephalin, which is mediated by delta receptor. Then there's another substance which is called as nociceptin, and this nociceptin, a new endogenous peptide, it acts on the nociceptin orphanin FQ. or you can say it orphanin like receptor. So we also write it as NOFQ. So nociceptin is a new endogenous peptide. This acts on this particular receptor. Okay. Next, what are the pharmacokinetic characteristics? Let's see the pharmacokinetic characteristic. Morphine is metabolized to morphine 3-glucuronide, and this morphine 3-glucuronide is excitatory in nature, or you can say it's neuroexcitatory, right? Then renal failure can lead to decreased clearance of morphine and increase toxicity, and it is seen that it can even precipitate seizures, right? Next है pethidine. Pethidine is metabolized mainly to methylene acid by mouth, and it is also demethylated to norpethidine. It can result in seizures, right, if it is used for prolonged uses. Then another thing is, we'll study the independent congeners also. So sufentanil is the most potent opioid, while meperidine, that is also called as pethidine, is the least potent opioid, right? So this is some important pharmacokinetics. Now let us see the actions of these drugs. Now actions में सबसे पहले तो action होती है CNS पर. तो CNS की जो action है, it produces spinal and supraspinal analgesia. सबसे पहला जो action है morphine का, this is spinal and supraspinal analgesia, ठीक है? उसके बाद आते हैं, they produce dependence, euphoria करता है, which is dependence producing action. Then they also produce dysphoria, as we have seen earlier. Another very important feature of morphine, tolerance. On prolonged use, tolerance develops to all actions except 3 actions, that is 3C, that is constipation, then convulsions and meiosis, right? So this is something very important in case of morphine. Next, they produce marked sedation, respiratory depression, cough suppression. Then meiosis occurs, and the pupil that we get are pinpoint pupil. It is a diagnostic sign of poisoning. Then highly lipid soluble drugs, highly lipid soluble opioids like fentanyl, sufentanil, they can also result in truncal rigidity on rapid IV infusion. Then they also cause nausea and vomiting. So these are some CNS actions. Coming to their peripheral actions. So what is their peripheral action on heart? Now they usually don't have any direct effect on heart, but pethidine and pentazocine, they increase the heart rate and reduce the blood pressure. Okay. Then they cause constipation. Here there is a drug which is known as Mopin. This is a peripheral opioid antagonist which is used for paralytic IBS. Then increase the intrabiliary pressure, and because of this they are contraindicated in biliary colic. So although they are analgesics, but they are not indicated in biliary colic because they cause spasms here. Then next, they increase the bronchoconstriction because they release histamine, so they are contraindicated in bronchial asthma, and they can even precipitate bronchial asthma in patients. Then next, spinal or epidural injection can result in intense severe pruritus over lips and body due to histamine release. They release histamine, and that is why they can do all these things. So these are some peripheral actions of morphine. Now let us see there are some drugs which are called as mixed agonist antagonist, and it is very important to understand their actions. A lot of questions are asked on these drugs. So the first drug which we have to understand is buprenorphine. Buprenorphine is a partial agonist at mu and antagonist at kappa and delta. So it is used as analgesic, and a very important thing is that it is used as alternative to methadone for management of opioid withdrawal, right? So this is first is buprenorphine, then next is nalbuphine, pentazocine and dizocin. These are agonist at kappa and they are antagonist at mu. So these drugs produce psychomimetic effects, that is, as you have seen earlier, they cause dysphoria, so there are hallucinations and anxiety, right? Then the third drug in this category is buterphenol. Now this buterphenol is a kappa agonist, right? So it produces equivalent analgesia but more sedation than morphine, right? Let's talk about other opioids also. Now the important ones that we have talked about, uske alawa in general about all the drugs. So morphine, hydromorphone and oxymorphone. These are the opioid analgesics, opioid drugs which are used as analgesics, right? Then there is a drug which is called as heroin. So this is a potent and fast-acting drug, fast-acting opioid, but it has got a very high risk of abuse potential. So that is why this drug is not very much commonly used. Then we have methadone. Now what is methadone? Methadone is basically a long-acting opioid analgesic, and it is given by oral, IV, subcutaneous, rectal routes. Now this is a very potent agonist at mu receptor, and it also blocks NMDA receptors and reuptake. Now because of these properties, so it is used in neuropathic pain and cancer pain, which is not controlled by morphine. Then plus, because of the long half-life, the dependence potential is very less, right? Now it is less, so it is used in opioid abuse treatment. It is also used in opioid rotation therapy. Now this it is also called as methadone maintenance therapy, right? Now what is done is that the addicting drug is replaced by methadone. So what happens is that it prevents the withdrawal symptoms and is less addictive, and slowly then it is tapered down and finally it is stopped. So this is methadone maintenance therapy which is given. Okay, next drugs that we have is pethidine and pentazocine, we have seen earlier also. Now they have anticholinergic properties also, so they can result in tachycardia. So they are totally contraindicated in myocardial infarction. Due to anticholinergic activity, they are safe in biliary colic and accumulation of metabolite, that is norpethidine, can result in seizures, right? Can result in seizures. Then next drug that we have is levorphenol. It is similar to morphine. Then we have propoxyphene. It is least potent and least efficacious analgesic. Then there is a drug which is called as diphenoxylate. Now diphenoxylate and इसके साथ एक और इसका active metabolite है diphenoxin, and another drug is the loperamide. They are used to control the non-infective diarrhea because of their constipating action, and they are combined with atropine to reduce the abuse potential. The anticholinergic unpleasant side effects will reduce the abuse potential, right? Then another drug that we have studied is buprenorphine. Now this buprenorphine, it exhibits a ceiling effect to its respiratory depressant action. Plus it is resistant to naloxone reversal. Okay, so this is about buprenorphine. Coming to more drugs, we have butorphanol and pentazocin, dazocin. They have psychomimetic effects due to their potassium kappa agonistic activity. Then another drug is ziconotide. This is used in intrathecal analgesia and it acts by inhibiting the sodium channels. Then there's a very commonly used drug, that is tramadol. Tramadol is a weak mu receptor agonist. It inhibits the reuptake of noradrenaline and 5-HT and causes analgesia, so it has got an analgesic effect. Ondansetron is seen to abolish the effect of tramadol because it inhibits its action on serotonin, and high doses pe tramadol causes seizures, right? Then another drug is there, that is tapentadol. This is a new analgesic drug, same as tramadol. Then we have eleuxadolin. This is a mu agonist and delta antagonist, and it is approved for oral treatment of diarrhea dominant IBS. जब हमने GI system पढ़ा था तब ये हमने वहाँ पे पढ़ा था eleuxadolin. Okay, then we have some antagonists. Now what are the antagonists of morphine? They are naloxone, naltrexone and nalmefene. Okay, so these are the antagonists and they block the mu kappa and delta receptors. Then we also have alvimopin and methyl naltrexone, which act at the peripheral. So they are peripheral antagonist. As we have seen earlier, alvimopin is also used in paralytic ileus, right? Now regarding these drugs, naloxone is given by IV route and very short acting. It is not effective orally. Then nalmefene is also given by IV route but has a long duration, longer half-life. Then we have naltrexone. So naltrexone is long acting and this can be given by the oral route, right? Then we have samidorphan. Samidorphan is a mu receptor antagonist. It is more potent and longer acting, right? Now these drugs, they are basically antagonists, so they reverse the action of opioids. By themselves they do not have any action, plus also they precipitate withdrawal in opioid dependent patients. If they are given in dependent patients, they will precipitate immediate withdrawal. So naloxone is used in the treatment of acute opioid poisoning, right? आगे देखते हैं. I'll write it here. Naloxone is used in treatment of acute opioid poisoning, right? Then drug naltrexone. This is used as a maintenance drug for opioid poisoning. Also, it is used to prevent relapse after opioid de-addiction. So it prevents the relapse also. Then इसके और भी हैं. Let's naltrexone also decreases craving in chronic alcoholics, but it does not reduce craving in craving for opioids, right? So this is naltrexone. Then naltrexone and bupropion, they are used for treatment of obesity, right? Then naloxone is also used in neonatal resuscitation. So this is the drug of choice in neonatal resuscitation to reverse the effect of morphine if it is used in labor, right? If mother is dependent on morphine, then naloxone should not be used, otherwise it will precipitate withdrawal. So if mother is dependent, then not use. Then naloxone is added with the opioid to reduce addictive potential. So what happens is when they take the combination orally, then opioid is absorbed and not naloxone. So then in that case opioid action is present but no addiction. But if you give it IV, then naloxone also absorbed and stops the euphoria, right? Then other drugs are there: methyl, naltrexone, naldimadine, and naloxegol. They are basically peripheral opioid antagonist, and they are used in opium-induced constipation, right? And the other drug, albumin, is used in post-operative paralytic IBS, right? Then another drug, I think we have done it earlier also, samidorphan. This is given in combination with olanzapine for schizophrenia and bipolar. So this samidorphan is combined with olanzapine for this thing. So here it reduces the weight gain by olanzapine. Okay. Then let us see about the uses of opioids. So अब आते हैं अपन यूजेस पर. यूजेस में देखो सबसे पहला यूज जो है इनका, तो द बेस्ट यूज इज दैट दे आर एनाल्जेसिक्स. सबसे पहले है ना, दे आर मोर इफेक्टिव इन विसरल dull constant pain, right? But they are contraindicated in biliary colic. Then morphine is used in myocardial infarction and pulmonary edema, right? Then codeine, folcodeine, and noscapine and dextromethorphan. They are basically very effective cough suppressants. Okay. Then after that, some more uses are there. Loperamide and diphenoxylate are used in the treatment of non-infective diarrhea. Then morphine is used as pre-anesthetic medication, and other drugs like fentanyl used as adjuncts. Fentanyl, so fentanyl, alfentanyl. Pethidine is used to reduce shivering after anesthesia. And why it is used in shivering? Because of its action on alpha-2 receptors. Okay. So these were some uses. We go to the route of administration. Then route of administration में देखो, morphine is given by oral, can be given by rectal, can be given by IV, IM, intrathecal, and epidural. These are the routes by which morphine can be given. Fentanyl is given as transdermal patch, can also be given by buccal route. Buterphenol is given by nasal route. It is the only opioid which is given by nasal route, right? Coming to the adverse effects. Adverse effects अगर हम opioids के देखें, they cause respiratory depression, nausea, vomiting, not diarrhea. They cause constipation, urinary retention, itching, dysphoria. These are some adverse effects. As we have earlier also seen, tolerance develops to all the effects except 3C, that is constipation, constriction of pupil, and convulsions. They are highly addictive substances and they lead to psychological and physical dependence. Withdrawal symptoms usually present as rhinorrhea, lacrimation, yawning, chills, mydriasis, vomiting, diarrhea, and anxiety. Right? So what are the contraindications to the use of morphine? Morphine is contraindicated first, contraindicated in head injury. Why it is contraindicated? Because it increases the intracranial pressure and also causes pinpoint pupil, which interferes with the neurological examination. Then pulmonary, kidney and liver dysfunction may they have to be used cautiously. Elderly and children may to be used cautiously. In pregnancy, if they are used, they can result in opioid dependence of fetus and severe withdrawal reaction in the fetus that can present if it is taken during pregnancy. So now let's see the addiction, treatment of addiction. Now, if addiction is of short duration and small doses, then you can give clonidine or beta blocker. Okay, but if it is a long duration addiction with large doses, then sudden withdrawal will be dangerous and you have to give a methadone maintenance therapy, which we have discussed earlier also. Isme buprenorphine can also be given as an alternative to methadone for management of opioid withdrawal. Then to prevent relapse, what do we use? That is naltrexone. Naltrexone is used to prevent the relapse because it prevents the euphoric action. So beta blockers, clonidine, they treat the withdrawal syndrome. They also treat the withdrawal symptom. Methadone prevents the withdrawal symptoms by continuing the addiction, but at a lower level. Naltrexone is used to prevent. So methadone is used as a maintenance therapy, and where methadone cannot be used, we use buprenorphine. So इसका एक बहुत clear cut मैं आपको वो बताती हूँ. I'll take another page only. That methadone is maintenance therapy in opioid dependence. Okay, and naltrexone is maintenance therapy in opioid poisoning. So please remember this difference. The questions are asked on this, and that is why I'm telling you to remember the difference. So with this we complete the opioids. Now we are left with two parts. One is the anesthetics, and we are left with antipsychotics, antidepressants, anti-maniac and anti-anxiety. So these 3-4 things will be taken in the CNS part 4, right? Or part 3, yes, this is part 2.